This PowerPoint presentation is a review of the basics of recurrent pregnancy loss. First, let's review some important definitions and numbers. The definition of recurrent pregnancy loss is having 2 or more failed clinical pregnancies. A clinical pregnancy is defined as ultrasound findings of a gestational sac plus a yolk sac, or a pathology and diagnosis of products of conception. Remember that 15 to 25% of pregnancies will end in a miscarriage or an early pregnancy failure. 5% of women will experience 2 consecutive miscarriages, while only 1% of women experience 3 consecutive miscarriages. Also important to know is that a definitive diagnosis is only made in about 50% of cases of recurrent pregnancy loss. I like to think of recurrent pregnancy loss in terms of 5 different categories. These are genetic, anatomic, thrombophilia, endocrine or autoimmune, as well as other or unexplained. Genetic causes of recurrent pregnancy loss include non-disjunction, translocations, inversions, deletions, and duplications. The workup for genetic causes would be to analyze a karyotype of products of conception, as well as to analyze the parental karyotypes. Looking at the karyotype of the products of conception most commonly will help you find non-disjunction types of genetic defects, whereas a parental karyotype analysis is more helpful for looking for translocations, inversions, deletions, and duplications. The treatment, if you find a genetic abnormality in the products of conception or the parental karyotype, would be to complete IVF with PGT for this couple. Anatomic causes of recurrent pregnancy loss can be separated into congenital and acquired anatomic defects. The congenital anatomic anomalies include uterine septum or the various Müllerian anomalies. Acquired anatomic defects include things like fibroids, polyps, or scarring or synechiae of the uterus. The workup for these defects can range from hysterosalpingogram, saline infusion sono, 3D ultrasound, or MRI, and the treatment can include repair of the defect. If the defect is not one that can be repaired and is contributing to the recurrent pregnancy loss, then you would need to talk about a gestational carrier for treatment. Thrombophilia is another cause of recurrent pregnancy loss. There are inherited and acquired types of thrombophilias. The inherited causes are listed here. However, a workup for the inherited thrombophilias should not be a standard part of your recurrent pregnancy loss workup. Your workup for thrombophilia for recurrent pregnancy loss should only include a workup of Anti-Phospholipid Syndrome. This is your lab's lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. For these antibodies, you want to check for both IgG and IgM. Only include a workup for inherited thrombophilias if that patient meets criteria for this workup anyway, with outside of their recurrent pregnancy loss history. So this would be if they have a personal history of an unprovoked VTE or a first-degree relative with a known or suspected thrombophilia. The treatment, if the patient has a known inherited thrombophilia, or if they have a workup for Anti-Phospholipid Syndrome and it's positive, would be aspirin and low molecular weight heparin. The endocrine autoimmune category is somewhat broad. It includes thyroid dysfunction, poorly controlled diabetes, hyperprolactinemia, vitamin D deficiency, as well as celiac disease. Recurrent pregnancy loss might be the first sign of an underlying celiac disease, so it's important to remember this one. The workup is specific based on what type of endocrine or autoimmune condition is underlying, so this would include your TFTs, as well as TPO antibodies for a thyroid dysfunction workup, an A1C to evaluate for diabetes, a prolactin level, a vitamin D level, as well as your TTG IgAs. And for treatment, it varies depending on the underlying disturbance, which you would want to correct. So remember, about 50% of cases of recurrent pregnancy loss will have a diagnosable underlying cause in the categories that we've already discussed between genetic, anatomic, thrombophilias, or endocrine autoimmune. The remaining 50% fall into this other or unexplained category. The specifics on this slide are less important to know for CREOGs, but I think can be helpful in our own learning and for counseling patients, particularly these modifiable risk factors, things like smoking, drinking greater than 3 to 5 alcoholic beverages per week, consuming caffeine in amounts of greater than 3 cups per day of coffee, any cocaine use or obesity can all contribute to recurrent pregnancy loss and could be a great thing that we can counsel our patients on early. There are thought to be also possible hormonal, male factor issues, alloimmune, or further unexplained, likely cytogenetic issues of the egg. I think the most important thing for the CREOGs on this slide is that if an individual with recurrent pregnancy loss falls into this category after a thorough workup of unexplained recurrent pregnancy loss, their chance of a future successful pregnancy leading to a live birth is about 50 to 60%. And this is also a great thing to know in counseling patients and an important statistic for our CREOG studying. I'd like to take a moment to review Anti-Phospholipid Syndrome here. In my own studying, this is when I tend to refresh my memory on Anti-Phospholipid Syndrome as a nice segue. Remember, you need to meet criteria in 2 ways. You need a clinical criteria as well as a laboratory criteria. Of course, first you will have a clinical criteria that causes you to find your laboratory criteria with a workup. So the clinical criteria a patient may present with that would trigger that workup would be a vascular thrombosis, whether it be arterial or venous, or a pregnancy morbidity. This includes a morphologically normal loss greater than 10 weeks gestational age, any morphologically normal preterm birth of less than 34 weeks, with a history of preeclampsia, eclampsia, or placental insufficiency, as well as 3 or more unexplained consecutive miscarriages less than 10 weeks, and this is where our recurrent pregnancy loss fits in. Notice that this definition is a little bit different than the definition on my earlier slide, so we are going to likely start this workup after 2 or more losses based on our definition of recurrent pregnancy loss. We already reviewed the laboratory criteria on my prior slide that we need lupus anticoagulant, anticardiolipin, IgG and IgM, as well as the anti-B2 glycoprotein IgG or IgM. You only need one of these to be abnormal, but it needs to be on 2 separate occasions over 12 weeks apart. So if on your initial lab draw all of these are normal, you don't have to do anything further. If one is abnormal, you will repeat these labs in 12 weeks. And if it's again abnormal, then you have met your laboratory criteria.